August 31st, and the Prescription Drug Abuse Task Force acknowledged all 645 accidental overdose deaths by creating a sign for each person that died. And you can see kind of, this is the end product you can see in this picture right here. Big, huge thank you goes out to Dr. Campman and Jennifer Effie for helping with this data. They were instrumental in getting us this data and helping us sort it. So the data is a little different from the report card data in that we just took these 645 accidental overdose and we broke them into these 5 categories you can see. And these are all related deaths. So they're fentanyl related, meth related. So if a person died with, you know, meth and heroin in their system, they kind of got sorted into both categories. They were both meth and heroin related deaths. So our final product for the signs kind of look like this. We went through a few revisions, but you can see kind of this top left-hand sign that has the gray tab on the top. So this person died only with fentanyl in their system. But there were some other, unfortunately, some other victims, like on the bottom right, where this 46-year-old man died with all 4 of these substances in his system. So meth, heroin, medication, and other. And generally in the other category, we had alcohol or cocaine. Those made up the bulk of that category. So 645 of these out at the County Administration Center made quite an impact. And we had really good participation from the media. People walking by were interested. They walked through the signs, they asked questions. So it was a great visual. When we finally took all the data and we crunched it down, we went through several graphics, but this was our final one. I think it's a great graphic. It represents exactly what we see the problem as. And you can tell on that bottom part of the pie, that red group that's methamphetamine, 60% of the deaths last year of those accidental overdose were methamphetamine related, and nearly 60% were opioid related. So you can see the opioids broken out there on the side. So fentanyl, heroin, and those medications in that group are the opioid medications. We also broke out non-opioid medications that you can see on the top of the graph. All right, let's see. So like I said, we had good media coverage, and our overarching message was that overdose is preventable and addiction is treatable. That's really what we wanted to get across. And we saw way too many people are dying from this, a huge age range from 16 to 77 across all the categories. Didn't matter, all races, all incomes. And one of our other messages was we can't arrest our way out of this problem. We all have to work together. You know, this is a great collaborative group, Pdatf, meth. They're a good collaboration of law enforcement, treatment, policymakers, and they are going to have to work together to solve these problems. Like we talked about, we do have both a meth and an opioid problem. The last thing is the next International Overdose Day for this coming year, 2021, would be Tuesday, August 31st. And I think everybody involved was interested in doing this again. So it'll be, you know, we can keep growing this and making it a bigger project and getting more awareness. Okay, that's it for this one. That's it for International Overdose Day. I'm going to switch to National Take Back Day. So 2 months after International Overdose Day, we had National Take Back Day. So that was October 24th. We ended up with 16 sites in San Diego County and 1 in Imperial County. And, you know, COVID really limited what we could do this year, but we were glad that we could get some participation. And I wanted to give a huge thank you to everybody that did participate, whether you helped at a site, whether you put it out on social media, whether you just talked to people and told them about it. We really did well this year with collecting drugs, and just a huge thank you to everybody that participated. You can see here, those 16 sites in San Diego County collected 10,000 pounds of drugs, of prescription drugs. We got 823 pounds from drop boxes. Imperial County only had 1 site this year. They only got 44 pounds, but that's because Imperial was still largely locked down. So we were glad they could do anything, and they had their 44 pounds. So giving us a grand total of 11,144 pounds for this take back day. So congratulations to everybody. So this is our traditional graph, just show it so you can see kind of historically how it's gone. So we were very happy with these results. I did look at, so this is by site. So we have our military sites over here, so you can kind of see where we picked up the drugs from. So we had military here. Orange here is all the PDs from cities other than San Diego's in there too. All of our PD sites. Nope, San Diego's here. Here's our SDPD in purple. Our sheriff sites are here. These are our registrant sites, the sites that actually where they have DEA numbers and they actually dispense from those sites, and Imperial County down here. And I thought it'd be kind of interesting. Hopefully I remember my regional providers. I know it's been, 8 months or so, but hopefully I broke this out correctly. Pounds collected just by region, so that you guys could kind of see where they came from. So we had 4 sites in the south, 5 in the central area. East only had 2 sites and collected 1,900 pounds. That's pretty amazing. Almost 2,000. And then our 4 sites we had in the north. Let's see, the next thing I want to talk to you guys about was Vista Community Clinic. Thank you so much. They generally can survey people, and they surveyed, I think they had 193 cars, and they got 197-ish responses from people that they surveyed them. How did you find out about Take Back Day? And this is really good information for us. So still this year, 30% from TV, about 30% from the newspaper, and a pretty good showing on social media. So it's kind of interesting to look and see where people are getting this information. So we really appreciate them being able to do this survey. And lastly, I thought you guys would be interested in this one. So this is total weight collected by state for the entire country. So you can see, I mean, that's a lot of drugs. That's nearly 493 tons collected, for this Take Back Day. So I think people were storing them up since we didn't have one in April. So they were getting them all stored up, and they really showed up and brought them out. So good job. I think I had one more announcement, and that is that the Prevention Committee, the Prescription Drug Abuse Prevention Committee, in the new year is going to start having virtual trainings. So keep your eyes open for that, and we will send out emails and try to get you guys into the trainings. All right. I think that's it for me.
Thank you, Kelly. Appreciate the overview and the presentation on Overdose Awareness Day and on Take Back Day. So great job,
Absolutely.
Great team effort. So
yeah,
appreciate
definitely.
it. Next, I'm going to go back to announcements and just give a quick reminder that our healthcare task force, it was formerly the medical task force and the pharmacy task force, they have merged to make the healthcare task force. That meeting is on December 11th at 12 p.m. and it will be virtual. And Dr. Terezio and Dr. Paitner are the co-chairs of that committee, and they're doing really good work, so I invite you all to attend. And then I'm going to just highlight 3 of our media events, and then I'm going to turn it over to our presentation. We did have the media event for the Safe Disposal Survey and Take Back Day. Our next media event was the report card, and that one, as you can see, our partners there. Both media events were very well attended by the media, and we got a lot of coverage for both. So again, like all the other events, great team effort. So thank you. So with that, I'd like to turn it over to Dr. Ronit Lev. Many of you know her. She is, I call her a San Diego icon. We had her back in Washington, D.C., and she has come home to us and is doing great work. And we thought, what a wonderful opportunity for her to share what the work that she did on a national level and share it with us here in San Diego County. So Dr. Lev, thank you.
Hi, everybody. It's such a pleasure to be with you and to be back. Bear with me as I share my screen and kind of tell you about my adventure. Of course. Ah. All right, one button I have to reach. There we go. Okay, so let me just double check that you can hear me and you could see me as I figured out
Yes, we can
navigated.
hear and see you
Okay,
perfectly.
great.
Thank you, Dr.
All
Webb.
right. Well, again, it's wonderful to be back, and thank you for inviting me. And I'm going to take this session to share with you kind of this amazing adventure that I had by getting to be at the White House and what I was able to do, not do, and kind of share that experience. First of all, I wouldn't have had this opportunity if it wasn't for all of you. And Amy, if you're out there, I have you like in most of the pictures here, and Linda. But I mean, really, it all started by participation here with the prescription drug abuse, with the county, with our different task force, and Sherry reaching out to me years ago, and just kind of went on from there. You have all been my inspiration and my guidance, and what got me there. Events from visiting at ONDCP to inviting the drug czar, James Carroll. His very first visit when he came into office was to San Diego to visit us. And partnership with Sam, that got me another visit at ONDCP. And really the night after Director Carroll came to San Diego, we put together a whole presentation for him that I didn't say a word, but I put a job description of a chief medical officer in there. And that evening he called me and offered me a job. So that's how it all started. I just really wanted to thank everybody. I realize not everybody knows what ONDCP is, so I just want to kind of do that. Everything has an acronym. ONDCP is Office of National Drug Control Policy. It is one of the several agencies that sits under the Executive Office of the President. So we work for the Executive Office of the President, which is part of the White House, along with other offices such as Office of Management and Budget, Security Council, et cetera. The power of ONDCP is controlling the budget of everybody's office that has anything to do with drugs. So if there's a federal office that has to do with drugs, Veteran Affairs, Treasury, even education, then all their budget has to be approved by ONDCP, and that's the power that they have. So $35.7 billion for 2021. And that is a way to coordinate drug policy. So you can't have transportation having one policy and agriculture having another policy. Drug policies have to be coordinated, and the power is the purse. Every year, ONDCP puts out a national drug control strategy, and the strategy is what all federal agencies use to follow their drug policies. And the three overarching aspects of the national drug control policy are prevention, preventing use before it starts, providing treatment, and reducing the availability of drugs in the United States. I came in right as the 2019 policy was published, but I got to edit and put in, some language for the current policy, which is nice. And as the only medical clinical person in the entire agency, I was able to put in, clinical aspects on safe prescribing, and make a couple edits. You don't know, everybody's making edits. You don't know which is going to be approved, which is aren't, but I think I got some of my language in there too. So that was fun. And this is what drives everything. This is data from the National and NISDA, National Survey on Drug Use and Health. 20.4 million people a year have a diagnosis of a substance use disorder. That includes all drugs. If you take out alcohol, it's about half that, but that's a lot. To share a little bit what life is like. So first of all, I went in there all excited, check me out, I'm going to the White House, look at me all happy, signing in, swearing to do all these things. And then you meet with the lawyers. I thought I met with them for 3 different days. They told me it was 3 different hours, but it seemed like days. And they tell you all the things you could do, can't do, can never do ever again in your life because you've had this job. And then I asked, did I even do the right thing by by coming here? I thought, well, you know what, shouldn't I have had the briefing first and then swearing in? It should have been the other way around. And then I had to learn a whole different language. I mean, I've been a clinician for all these years. And, what's a SCIF, secured facility where you'd have to take your cell phone out and your watch and can't go in, and they watch everything that goes in and out. A burn bag, nothing can go in the trash. Only like things that you ate can go in the trash. Any paperwork goes in the burn bag. But it was still nice. People say, oh, it must have been so stressful. And really, as an emergency physician, it was not stressful. I had hours, I had off weekends. I can go to the bathroom whenever I want. I had a little electronic desk that goes up and down. I had a reserved parking spot. I really liked that, taking ONDCP number 1. And I even liked the guy in the windows cleaning it. Where I worked is considered part of the 18 acres. I was not in the West Wing. The West Wing has very limited number of people. There's a big building next to it called the Eisenhower Executive Building that houses most. And then the White House expanded to the 18 acres. I was part of that 18 acres. And what we do mostly is edit documents. And I consider it kind of like seeing patients in the ER where you go from patient to patient. We went from document to document. Okay, we have a deadline in 1 hour. Review this, and did things like a murder board. I was like, okay, I'm going to be in a murder board. I don't even know what it is. What is a murder board? And that was where we prepped the director to getting murdered in front of Congress. So writing talking points and practicing. And so that, we get to write his talking points of what he's going to say, and that gives influence. So that's a way to educate and spread the word much farther. So that was something. And then I got to write a presidential proclamation about addiction and treatment, and it's really amazing experiences. When I came there, I really came in focused on what I wanted to accomplish. And I went back in preparing for this presentation, and the list that I created for myself for 10 things that I wanted to do while at ONDCP. And I had to ask, okay, how do I do this? These are things I want to do. They said you have to write a proposal for each of these things, and make sure you don't type anything, don't write anything, don't even open a Word document without saying draft, confidential, pre-decisional, deliberative. Okay, so I'm not making promises, but this is how I can start doing things. And this was a list I wanted to create. Formulary changes, and I really everything here comes from the work that I did in San Diego and interacting with you when I was invited to be part of the community health group task force. It was amazing to be able to do changes for formula. You could go doctor by doctor and say, hey, you guys need to learn to do this, or you could just make a formulary change, and presto, everybody's kind of practicing the same way. And I said, if we can go to CMS and they're the ultimate formulary for the entire United States, you can make a big impact. And I had specific things in mind. I learned a lot because for each of these things, I went out and learned who the people are in charge, how to get things done. Didn't really accomplish the specific formulary changes, but I was able to put in safe prescribing and move beyond opioids, because everybody was just focused on opioids. I was looking ahead at benzodiazepines, marijuana, meth, everything else. So I gave myself a yellow because I kind of did that. I wanted to get naloxone is there's a lot of barriers still to get patients to have naloxone. You need to have insurance. You have to be able to go to the doctor. A pharmacist has to be able to dispense, and even if they can, there's barriers to them. I said, why don't we have a downloadable prescription? We talked about that here in San Diego, didn't really go far. And then so I said, hey, why doesn't the White House do this? Why doesn't the Surgeon General do this? And I met with FDA. What does it take to make it over the counter? And I learned about, why it can't be over the counter. And I give myself a red, like I failed at that one. But you'll see that I just came home and I just did it myself on my own website now. So I didn't get that done. When you order Suboxone or MAT, any drug, if I do, it goes into the PDNP system. But if you get it from methadone clinic or other MAT clinics, it doesn't go in the PDNP system. And that creates two different communications that don't talk to each other. And it's essential for each of us to know what the other one is doing. And this actually did happen. They have passed laws that it's almost there that could be communicated. And so that I gave myself a yellow because it's not done yet, but it's on the way. I failed at removing patient satisfaction, but I did learn a lot. It's $1 billion industry that's revenue neutral, and there wasn't enough oomph by the medical community really to remove that. Marijuana dashboard, I gave myself a red, didn't accomplish that. I had several meetings, and the vision was to create a dashboard like we have for opioids so we could start tracking the problem. And we kind of sketched out the data that is available if we had such a dashboard of the things that we can put in there, not just deaths, hospitalization, traffic, fatalities, but existing data on use, but that didn't quite happen. I did give myself a green for getting Suboxone education for emergency physician. I took the 8-hour course that it requires to prescribe MAT, and I found it not as useful and not specific at all to emergency physicians. I ended up having way more questions than when I started out with. And we were able to do the very first course of MAT specifically geared towards emergency physician. And I got to give the keynote speech at that event. So I gave myself a green on that one. Another idea was getting poison centers to be backup for Suboxone for physicians when they have questions. That didn't get very far. Public health response to overdoses, that concept, I gave myself a green because it really moved along. And here, even now in San Diego, you'll soon hear about a project called CREDO, Community Response to Drug Overdoses. So that movement went well. And the reason it went well is because I had this idea. There were other people who wanted it too. And we joined Department of Homeland Security and National Security Council wanted to do the same thing. So there was a partnership. I did get far with removing the X waiver but when I started at ONDCP, that was no deal. It was like, don't even bring it up, not possible. By the time I left, I was able to write an action memo, got letters of support from 26 different agencies, a lot of medical associations that said we need to get rid of this. And then when COVID hit also, right? I mean, we're giving all these medications and treatment for a disease that we're just learning about and didn't even know about. Can you imagine having an 8-hour course before you could do that? Can you imagine getting an 8-hour course before prescribing insulin? If these medications are really life-saving and essential, then why are there these barriers that don't make sense and don't apply to anything else in medicine? So we're really able to get that message. There's still, but it still didn't happen. So I gave a yellow for that one. And then getting ONDCP's message throughout the community, I get myself a green. So really overall, if you look at just this card, I'd give myself a C, harsh grader. But I got to do things that I didn't even have on this list, and I'm going to share some with you. First of all, visits. They say it's not what you know, at the White House or in federal governments who you know, and I knew nobody. So I made it a mission. You know, whenever I was there, I went and met with people. There's only a handful of doctors that work at the White House, so we would get together. I was invited to that little circle. About once a month, we would have breakfast and discuss what everyone else is doing. And I made it a point to go, not just to invite, but I went out to FDA. I went out to CMS. I went to DEA. I went to Department of Homeland Security, to other agencies I didn't even know existed, like NIST, and went and visit and met and made connections. And then our job within ONDCP is also to get the director to visits and meet people. So I was able to do a few of those for the director, where I was the one to coordinate it all, be the handler, arrange for the carpet. I didn't know what the carpet was. I thought it was a red carpet, like Aladdin. You know, like I get to get on the magic carpet. I found out that carpet means, you know, the Black suburban that brings, you know, important people, and it's called the carpet because when Roosevelt was the president, he had carpet on the ground to help with his polio, so it was called the carpet from then on. So I arranged a visit here. We're taking the director to Walter Reed, which was an incredible visit, and the same person who discovered dental implants did the same type of methodology for implants for amputations and how that technology works, and took them around there, and they have an amazing program reducing opioids, even for people who've lost limbs, getting pain management. So that was really interesting, to recovery centers and et cetera. I was able to do 20 different speaking engagements, which is unusual. And people invited me, and I got permission to go to some, not all of them. And that was really something that I enjoyed doing, bringing the message for ONDCP. I'm told that I'm the first person within the White House who was allowed to speak on marijuana. I was not allowed to say any policy. There's no specific policy from the White House, but I was allowed to say that I'm an emergency physician and this is what I see when I treat patients. So, that actually caused a little, hoopla in the office. Are you allowed to say that? But I was allowed to just speak to my own experience and kind of separate that from any White House policy. And my eyes opened up to different things. I mean, there's San Diego has a fairly small Jewish community, but DC, Baltimore is a huge Jewish community. I haven't seen synagogues that huge. And I was able to speak to rabbis and parents and students in the same room about marijuana. And I really realized that, whatever problems we have at large affect any little niche community you could ever think of. Like, I wouldn't have realized that there was such a problem with drugs at this little niche community, but they do. And it's something that they address, and really made me realize that no matter where you go, you have this problem. I did not get to speak at the press secretary. That's just me posing and pretending. Right away, I was invited to be part of the National Academy of Medicine. It used to be called the Institute of Medicine, and join in their Countering the U.S. Opioid Collaborative. And they have 4 different, when I started, now they have 5, but when I started, they have 4 different committees, and I was sat on 3 of them, representing ONDCP, health professionals training, educating the medical community. That one on pain guidelines and prevention, treatment, and recovery. And again, building relationships with other professionals. And I even invited them to do webinars with me from the National Academy and the heads of the medical schools, the heads of ACGME, ACCME, all these acronyms for people who really control our lives in the medical community, and got to join them together in a webinar that I led about addiction medicine and what the medical community does. So that was pretty amazing. This is one of the very first things that I did that I really wanted to do, is get a different graph on the overdose deaths that differentiates the supply chain from law enforcement needing to do something about and medical community as far as the supply chain, right? Really anybody, these are the 70,000 people who die a year. All of them deserve treatment with compassion and no stigma. But when it comes to supply and prevention in supply, there's, I don't prescribe heroin or methamphetamine or cocaine, but I do prescribe benzodiazepines and Benadryls over anything that's medicinal. I think that that's something the medical community can do something about. And so worked hard with, I went straight to the people who get this data in the first place, which was very exciting for me, because I always go to click on CDC Wonder and the national mortality data. So I went right to the source, spoke to the people who head it, which was amazing, and confirmed this type of data. And the red part, so I see if the top of the black graph, that's everybody who died from any type of drug and any intention. That's all intention, suicide, homicide, accident, and all types of drugs. But if we hone down to the red part of the graph and look just on medicines, then and removing fentanyl, you have to take out fentanyl, and they put fentanyl as a medicine. So when you look at data, it looks like the medical community is not making any progress. But if you take out fentanyl, that's 99% illicit of people who died, then the graph looks more like red, and we could show that there is improvement. But if we want to get better, we need to change our conversation to just opioids to safe prescribing. And I was able to work on that message, work on these graphs with the people who head them, and really ask them to take out pseudo with synthetic opiates other than marijuana from fentanyl when they talk that mortality data. And I think I'm almost there. I got them convinced, but I think still see if you're looking at national data, it'll be confusing because they're including fentanyl in the prescription piece. And if you take it out, it's only 22% of the whole is actually prescriptions. And you could see, these graphs. Again, it was really exciting for me to talk to the geniuses who come up with this data, and they did this for me. It's like if you take just opioids, it's 1. If you take pseudo, it's out, and you have to actually remove everything, including the overlap, to just get prescriptions. And then you could see that with this yellow part of the graph. And it makes sense that we should see decrease in mortality because this is the prescriptions, and this is data from 2018. Now I bet it's even lower, but we made really dramatic changes. I'll show you data from California. At ONDCP, I have the national data, which is a little older, but you could see 2011 was the peak of opioid prescribing with about 72 pills per adult American in the United States for opioids. And we've got it down to 34. I mean, great improvement. And we were, in 1992, we were at 22. I don't know if we really need to do that as our baseline. People say we were under prescribing at that point, and squeezing harder here would just mean people who really need it, who don't get it. And I also dealt with that. I talked to people who committed suicide. I mean, they didn't, their loved ones committed suicide because they couldn't get the medications that they needed, and they couldn't live with the pain and had terrible outcomes. So I mean, squeezing further just on opioids can have unintended consequences as well. And I was able to form and invite and lead a working group, IWIG, everything has an acronym, Interagency Working Group, and I had people from FDA and NIDA and other agencies and the VA as part of this working group. And we were able to do several things. One of the things is what you undo, not just what you do. Sometimes it's what you undo. But there's national performing metrics that, when they fall short, you say, hey, we need to do something about it. And so one of the metrics is more physician education. We need to do more physician education. We got all federal federally employed physicians to take this mandatory courses. We need the rest of the medical community to do that. And I was able to gather data through my connections with the National Academy of Medicine and the medical schools to show that everybody's already doing something. ACGME, they already have a program to address these things. We don't need another, bubble to check, and we should really retire that matrix. And I made that pitch. I think everybody in this working group agreed with it, and I think that that'll actually happen. So I give myself an A on that one. I also did a couple webinars. We did 3 webinars as part of this working group that went out to a national audience about healthcare professionals. I learned that if I say medical care, that may exclude some other people. They wanted to use the word healthcare to be inclusive of everybody in the healthcare profession, and what is being done for safe prescribing. And I got together a group of surgeons who are putting together what's called ERAS. They have an ERAS movement, Enhanced Recovery After Surgery. That still needs to be really universal in surgical treatment, leading to better outcomes, decreasing hospital stay, less pain, and less opioids by using this type of methodology. And I also participated in a webinar on peer recovery in the emergency department. There are other places out there that when you call 911, you get an ambulance, but you also have a counselor that comes to the emergency department and just sits there to be the coach and to help that person who almost died from an overdose. So I wanted to share, this is not ONDCP, but some of the data that I put together in preparation for here so you could see where we are in California and how we compare San Diego to California. And I got this from our own PDMP system. And if you look, you'll see that San Diego is blue, California is red, and this is total opioid prescriptions. And we really had a dramatic decrease in prescription. As a matter of fact, we are at the lowest, both in the state of California and in San Diego, it's ever been since we've been measuring anything in the PDMP system in San Diego, which is 2008. Here we have, 2010 data. So really, kudos. And we don't, we always want to, talk about the bad things, but really need to celebrate the amazing achievement that you guys put together before I ever came. And I was invited by the people in this leadership to come in years after, the regular overall community started prescription drug abuse task force. So really, this is an achievement that you have done, we've all have done. And so these are prescriptions. And doctor shopping, we talked about that as a big problem. We had doctor shopping, DEA had, enforcement against doctor shopping. We've had 1,300% decrease in doctor shopping since we've done all this. There's in San Diego County, in California, there's 1,711 doctor shoppers. In San Diego, I don't think I have that data, but it's only a few hundred. There's a handful. We could figure out probably who they are. But that is a huge decrease, and I think people may remember the day where, like, okay, you're a doctor shopper. Now we don't see that as much. Opioid and benzodiazepines, again, kudos to the efforts from the healthcare task force, really taking this on and being the forefront. And here is the fruit of your action. You're ahead of the curve for the rest of California in not having as much opioid and benzodiazepine as other places. Buprenorphine, I don't really have an explanation for that, why San Diego is, doesn't have as much buprenorphine access as the rest of California, but something to work on. All right. I tend to be an organizer by nature. So when I came to ONDCP, I wanted to figure out who the other docs are, who the other chief medical officers are, and get them together and learn from them, and then exchange messages. And I was able to do that. First of all, it's astonishing to me that I even knew all these little alphabet soup, AHRQ, ASPR. I actually know what all these acronyms are, Customs and Border Patrol, but I invited all of these people and each of their chief medical officers, and some of them didn't have a chief medical officer. So at first this was going to be the Interagency Chief Medical Officer Council. But since not everyone had a chief medical officer or a doctor, we changed it to Medical Leadership Council. And this was a historic event. White House has never had one of all these medical professionals all together at ONDCP. So we took a picture with the director and the people there, and had an amazing meeting. You could see there at the bottom of the table of sharing. I got everybody to give a presentation of a single topic. There were too many of us, but say one topic that would benefit other agencies from learning about. And that meeting bear fruit until this day, because I had NIST at the table. That's never invited really in this way to the table. That's the National Institute of Standards and Technology. They create standards for free for other federal agencies. And now CDC's mortality data is working with the standards people. Even after I left ONDCP, I was able to put these people together to create better standards for the work that Dr. Campman does at the medical examiner's office that reaches to a national level. So there's standards in reporting and et cetera. So this was really a fruitful meeting. People really enjoyed meeting each other, sharing each other's contacts that they usually didn't have, and promoted each person's work. I mean, the Surgeon General said, these are my top priorities. This is what we can do. We can increase messaging. We could do advisories. So everybody was able to promote each other things or even know about what each other was doing. I learned the power of the White House through events. The events promote an agenda. So the White House didn't actually do or create addiction medicine fellowships, but they create an event, and an event they invite important people or influencers from around the country to the White House to participate in a panel discussions and workshops that address the workforce of addiction medicine. The vision is that wherever you go in America, if you have an addiction problem, you get referral to a specialist. Just like if you come in with a broken arm to the emergency department, I'll refer you to an orthopedic surgeon. But right now we don't have the manpower to do that. And that's what these events are for. When we started, there was only 50 addiction medicine fellowships across the country. We still don't have any in San Diego, by the way, if there's someone who wants to take that on. We do have addiction psychiatry fellowships at UCSD, and they got expanded from work that ONDCP did to promote through HRSA grants, but we don't have addiction medicine fellowships. But after this event and getting people who have influence, they went home, talked about it, and now they're increased, the next day, they're increasing applications to enhance addiction medicine fellowships. We did the same thing. Let me go on. Credo is another project that I worked on, community response to drug overdoses. This is NIST, the National Institute of Standard and Technology, got a little tour. It's actually a whole, facility with multiple buildings. But these are the geekiest people on the planet, where the kilogram is not accurate enough for that. And they need to create it more accurate because that'll have another digit and that could compress data and things that above my head. They can test fentanyl in the air at the airport and do computers to do that and figure things out. But the Department of Homeland Security felt that fentanyl and any other type of emergent drugs can be a national security risk. And the National Security Council got together and created this mission called CREDO, Community Response to Drug Overdoses. And the vision was to create a national standard, similar to what happened with active shooters. We had active shooter events in Orlando, Florida, in Nevada, in Las Vegas, and overall, each agency kind of handled things differently. And by creating a national standard, right now, if there's an active shooter event, and I imagine that the one that happened at my home in Poway had a more unified standard approach when it came to law enforcement, medical response, even social worker. The whole aspect of responding to an active shooter has a consensus standard that's national. And they wanted to create such a standard when it comes to responding to overdose clusters. And we got, far with the concept and application for standards. And I still am in touch with the folks who are doing that, because it's not a complete project, but they still want to move this forward. We had an event kind of like we did for addiction medicine, bringing health insurance and behavioral health insurance workers to the White House for an event to promote parity for not just mental health, but also for addiction health. We want parity for physical health, mental health, addiction health, and really brought the top thinkers in these fields in these, in insurance companies to the White House, similar event to elevate this. And when we came out from that, I thought, what else can we do? I mean, we could get them together and insurance covers this, doesn't cover this. But what if we apply the standards that I just learned from the geeky guys next door at NIST and the Department of Homeland Security, and I will just copy the same thing they did are doing for national overdoses for addiction medicine? Why don't we have a national consensus standard that would elevate the field of addiction medicine? I mean, there's a lot of amazing programs out there, but there's also fraud that preys on a very vulnerable population. And this is a way, instead of like calling out the fraud, is really to elevate the whole field. And came up with a name. So I got to create my own first acronym, National Consensus of Addiction Treatment Standards, and put together the concept, get buy-in from all that. Remember that long list of alphabet soup of medical leaders who said, yes, this is a good idea, we should do this. And then fell short of, money, and is this where the agency is going to go with their time? And so it got stuck there. But never know when things can be revived. And really, I love addressing people, but I did take a picture, like, here I am at the White House leading a panel of these incredible people. Again, I had to really, I never took it for granted, and really pinched myself as I was there. And I always realized that this was a limited time, and I'm just going to go, as many of you know, and push to whatever I can. And I said, the worst thing they could do is fire me. Everybody gets fired here anyway, eventually. So I'm just going to try to, whatever, within reason, get done. And so that came, that is on paper now for anybody else to be able to take on and happen. This is probably my favorite project, because I was able to get my friends in San Diego get something to happen on a national basis. But we were approaching DEA Take Back Day that goes to all communities around the United States. But we were in the middle of an epidemic of vaping, and we still didn't know what it was. Good thing we didn't know what it was, because if we knew on the onset that this was a chemical epidemic, we wouldn't have had the CDC involvement, because they do just infectious diseases. And luckily, people thought this was an infectious diseases, and there was an all hands on deck approach to this, to the vaping epidemic. But I thought, what can we do? What can ONDCP do? Or ONDCP actually coordinates with DEA for Take Back Day. I thought, we need to take back the vaping products. And we don't know what's out there. We shouldn't just be taking prescriptions. I'm already thinking ahead. The prescriptions, I mean, that's good, but we're really don't have so much of a prescription epidemic anymore. Maybe it'll take a few more years before the rest of America realizes that. But really, this vaping, this is the hot subject now. And I wanted to add Take Back for Vaping. So I called my friends and Joe and Linda. I was like, okay, can we take back vapes? They gave me some information. I contacted EPA. The beauty of working at the White House, Dr. Lev calling from the White House, can I speak to whoever? And it's like they answer the phone right away, got to whoever's in charge at EPA of safe disposal, able to write a little protocol. This was a good time at ONDCP because there was transition. It's like, what are you doing, Dr. Lev? Don't promise anything. Ask the lawyers before you do anything. It's like, okay, ask the lawyers, can I do something? I'm not promising anything. I got all the little deliberative things on the paper. I got to get feedback. And it's like, okay, it's a great idea, but we can't do something new unless there's communities out there who are already doing it. And then I call Linda, Joe, hey, can we do some, can you try to do take back of vaping products or something, you know, that you could say that we're doing or attempting? And they said, we got it. And I said, okay, well, you know, people in San Diego are doing this. Everybody should be doing that. And really, I wrote a whole protocol. And then I got, you know, stand back, Dr. Lev, you know, no more work on this project. And I said, okay, you know, I was going to have one more meeting with EPA to right before Take Back Day. And I didn't really know what happened with that idea. I thought it was another great idea that didn't go anywhere. And then next thing I know, First Lady Melania Trump is tweeting, hey, so happy that we're taking unused drugs, including vaping products. So there we go. Policy did go through. I don't really know what happened between the stand back Dr. Lev and the First Lady tweeting that, but there we go. How I measure success. I showed you my list that I gave myself a C for, but I realized that I'm really measuring the wrong thing. I was measuring like I would if I was here at home with you in programs, but measuring success there is getting other people to say what you're saying, to think like you, and then they spread it on a higher level. So my measure of success is people in federal government now know what scromiting is. And I almost got to get Dr. Nora Wolkoff, the head of NIDA, National Institute of Drug Abuse, to say that in front of Congress and television. We get to edit the comments before their testimony from the Surgeon General and NIDA. And I got to see what they were going to say, and I wrote in scromiting. And that got edited out. They didn't use that, but even better, Dr. Wolkoff acted it out and talked about, you know, terrible, horrible screaming and vomiting. And I got to meet with her in person and showed the data that we are putting together. That shout out to Joe for his report card. And she used that in her testimony to Congress. And she learned a lot. You know, I learned a lot from her, but she learned a lot from us. So she didn't know about barotrauma associated with marijuana, and she didn't know about scromiting. And so really, I continue to email her to this day about different ideas. And so that was really rewarding. Those are kind of the projects that I worked on. And, you know, through it all, I'm going to share some personal experience as well. They said it's like not just what you know, but who you know. And I was very starstruck to meet the various people, the superstars, I think, in government. This is Miriam Adelson, Kellyanne Conway, Ben Carson, and Ronnie Jackson, Sean Conway. I mean, you know, emergency physicians have a bond. And I realize that we are a divided America when it comes to politics. And so just know that if you met anybody at ONDCP or anybody who's talking about the issues of drugs, this is really a bipartisan issue. And you would not be able to identify any one of us as an R or a D when it comes to this issue. You would identify absolute passion and commitment to working to this problem and to helping Americans. And you really, that is an issue that crosses the aisle. And I'm very, really proud of doing that. And of the people I met, I want to call attention to this gentleman here, Dr. Jerome Jaffe. And he is the very, very first drug czar of the United States. He's an addiction psychiatrist who served under Nixon and took me on as his mentor. And I had dinner with him, like, once a month and several times, and really taught me a lot about what happened in the office. He's a living history book under Nixon when people were coming back from Vietnam addicted to heroin. The policy he implemented of drug testing before you get to come back from Vietnam got people to quit. And they stayed off of it when they came back, not just because they were with the community of people, but because there wasn't access. We didn't have availability. And again, importance of law enforcement in decreasing the supply. Anyway, that was a really special relationship that was developed. And then it really, again, as I told you, I'm like pinching myself to be there, participating in Director Carroll's, when he was confirmed by Congress, bowling at the White House. This picture cracks me up. There is a service dog on the White House furniture. I thought that we were going to have Secret Service, kick us out of. I can't believe we did that. And there were some really special things that never happened before. This is a Jewish holiday called Sukkot. It comes after the New Year, and you build a little booth and you sit in there and eat. The White House never had a sukkah before. This was the very first one in history, and I got to go there and be there. This is 9/11, where they got all the staff that works on the 18 acres to come and be there for a moment of silence. I got to eat at the White House mess, and I am just like a little kid. I'm taking pictures of the butter that has a little insignia there. Last year I got my flu shot at the White House. I got to take a picture of that. And then all the little, presidential tchotchkes at the bottom there. And again, by working at the 18 acres, you get to participate in different tours. I was able to, anybody who came to visit, get them a tour at the White House. And then I have a friend in Congress, and she was able to get tours at the Capitol. So we had a good little gig going on for our friends. I got to be there for the funeral of President Bush at 4th of July when the Prime Minister of Australia came to visit. And you can get tickets when the president's not there to sit in his box at the Kennedy Center. And I got to see several performances there, and the White House Christmas tree lit up. So it was really memorable. And then I do want to just touch on personal things, because after the Chabad of Poway shooting, my personal life, professional life, drug life, ER life, all that got mixed up. And this is all happened while I was working at ONDCP. But this is a picture of my best friend, Lori, who this is the last picture of her alive before she was murdered attending my daughter's graduation. And, things, and many of you have been so supportive to me after that event. And shortly after that, I went to a shift in the ER because I commuted still from DC to Scripps Mercy. And I was assaulted at work by somebody who I think was on meth, and they called 911. A SWAT team shows up in the emergency department, and that was kind of hectic. But I was able to take that experience also back to the White House and say, what it's like to, as far as workplace violence. Again, a topic not for ONDCP. ONDCP doesn't talk to environmental protective agencies or even the smoking department, because that's not our lane. But with these experiences, I was able to cross lanes even within the agency to share these kind of experiences. This was a freaky event because I was looking at social media and saw a little red circle around my head and a picture with the First Lady. And it said, Dr. Lev, best friend, and a whole little association of scripts and the White House and me. And I felt like this was a target on my head, and it freaked me out a little bit. And FBI came, did a little investigation, calmed me a bit and said, these are just, I guess, weirdos. You can, freedom of information. It wasn't an active threat, even though it's unsettling to find a red circle around your head on social media. Through this whole thing, opioid lawsuits, and I got called to testify and give a disposition in a lawsuit while sitting at the White House. The White House didn't like that, called a bunch of lawyers, and I had to sit for a deposition with White House lawyers that flew in to San Diego. The deposition was in San Diego, and they were there to defend ONDCP. I was not allowed to talk about anything that is related to work at the White House. Just my experience before, and a bunch of lawyers for a big pharmaceutical industry. And there I was alone, really nobody was representing me, but it was an interesting experience nonetheless. Happy things during that time, my daughter is wearing her Navy hat, and foreshadowing, because my other daughter was wearing a Krispy Kreme hat, and eventually she joined Navy as well, and they're both now serving together with matching hats at Maryland, and it really gives me a lot of joy. And also, while sitting at the White House, I planned a wedding for 250 people in Coronado for my son. And I use that as an example because I went to meetings at ONDCP. I may be sharing too much, but I had to hear a presentation about those metrics and how to enter data into Excel file. And the analogy, they said, if you're having a pizza party for 12 people, you need to order pizza, and then you need to enter it in this box, and then you need to call and invite your guests and invite in this box. And I told this person who was organizing a different younger generation than me that if I had to enter into an Excel file for a pizza party of 12 people, I would never be a wedding for 250 people, and someone else has to be kind of clicking these kind of boxes while I just get the work done. And again, that was an incredible experience. I got to very early in COVID, remember when we were all scared and stayed home. And I was seeing COVID patients, and White House didn't yet close down, but they said, Dr. Lev, why don't you stay at home and telecommute, and didn't want me to come back and infect the place. Meanwhile, I have never had COVID, and a bunch of people there have. But I continued to telework until May, and that really helped out locally, because at the beginning we had physicians who were sick or out in quarantine, and we really needed the extra hands on deck. And I realized that that's my calling. Ready to, at that point, I thought I could die for taking care of patients, and I was ready to do that, as well as all of us. And now we have a lot more information. I actually feel way safer at work than other places. But again, really an amazing experience. I take that experience not to like it's over, but now I understand the system, not perfectly, but I have some friends, I have some connections, and when I sit here and work with you at San Diego, I want to help my community, and I see us as kind of like, work something, a good program here in San Diego, and if it works well, then it can go national and can make that happen. So I'm here to stay in San Diego, work with all of you, really love working with all of you, but also when there's a good idea, I can be able to expand it. And actually I have more ability to do so, not being a federal worker than I did when I was working for the federal government. And one way I want to be doing that, and I want to promote High Truths, which is a podcast that will air. The introductory episode will be in December. The regular series will start weekly, starting January. And I'll be bringing experts to answer questions from you, our listeners, each week, which it's really fun for me to do, because I get to get all the people I have met and talk about various agendas that are related to drugs, and bringing out new ideas and innovations and solutions. So that's it. Let me know if you have any questions.
Thank you, Dr. Lev. Because of time, we're gonna, people have been asking questions in the question and answer box, and we will respond to them as best we can, and we'll make sure that at the end that any questions that need to be answered, we'll meet with those people directly. So thank you. San Diego County is lucky to have you as our champion. So thank you for everything you've done. I'd like to now turn it over to Alicia at the Rescue Agency. At a previous PDATF meeting, we had a presentation about the opioid project. It's a project in partnership with the San Diego County District Attorney's Office and San Diego County HHSA. And Alicia's here to provide us an update on the opioid project. Alicia?
Thank you so much. I'm going to go ahead and share my screen now. Just 1 second here. Presenter mode. Okay, Marla, can you see my screen and both hear me?
Yes, I can. I can see you and your screen is showing. Thank you.
Perfect. Thank you so much. All right, so San Diego Opioid Project has come to a wrap, and we have some exciting news to share. So taking it back here, back in the beginning of 2020, the DA's office partnered with Rescue Agency, who I'm representative of, to create the San Diego Opioid Project. And we wanted to develop a media campaign that is devoted to lowering the number of opioid-related overdoses each year in San Diego County. So this campaign really was a three-phased approach. So think of like 3 mini campaigns in a larger holistic campaign. So the first one was called Rabbit Hole, and Rabbit Hole worked to reduce prescription opioid misuse by increasing knowledge of what prescription opioids are, how they work, and how the risks of using prescription opioids and the risks of using them other than prescribed. It communicated the similarities of opioids and heroin in order to reduce misuse of prescription pain relievers, as well as increase the perception of risk associated with prescription pain reliever misuse. It really built foundational knowledge in our audience of what opioids are and what they're meant to treat and how they can be misused. So I'm going to quickly play our 30-second commercial here for Rabbit Hole.
If you take prescription opioids like Vicodin or Percocet at the party, it may not look like much on the outside, but serious damage is happening on the inside. Everyone's brain has receptors that regulate both pain and emotion. Opioids attach to these receptors just like heroin does and create the same type of addiction because chemically, they're almost exactly the same. So no matter if it's a prescription opioid or heroin, they're both seriously dangerous drugs. Learn the risks of prescription opioids. If you take prescription opioids like Vicodin or Percocet, San Diego Opioid Project.org.
So you'll notice all of our commercials drive to our main website, which is San Diego Opioid Project.org. So that was our first campaign, ran in February for 8 weeks. And then our second one launched in June. We had a little hiatus because COVID hit and priorities were being figured out and all that. So we paused a little bit, brought back campaign 2 in June. And this one is called No Drama, No Help. And this one really worked to demonstrate the messaging about the dangers of opioid overdose and to make it feel personally relevant to our audience. So it takes opioid risk from extreme, like overdose images in the news, to relatable, with settings of people who look and act and feel like our audience here in San Diego. No Drama, No Help established the relevance of risks by showing the consequences of mixing opioids with alcohol and drove home that foundational knowledge from the first campaign with further prescription opioid name education. This campaign really worked to define the chemical interaction that occurs when mixing opioids and alcohol and communicated the heightened risks of this combination. So now I will play our 30-second commercial for No Drama, No Help.
The signs of opioid overdose are hard to notice. If you pop an Oxy or Perc while drinking, the mixture can make you drowsy, slow your breathing, and lead to organ failure. But those changes are so subtle, they can be easily overlooked. Because the truth is, overdosing on prescription pain pills looks similar to sleeping. So no one knows to help. Learn more to prevent another opioid overdose.
Great. And so then campaign 3, which just ended in October, is called Instant Death. And Instant Death works to prevent San Diegans from using fentanyl-laced opioids so they don't face life-threatening consequences. And we did this by increasing awareness and knowledge of the risks of laced opioids in San Diego County. This campaign really focused on how little fentanyl it can take to lead to immediate death and how illegal opioids laced with fentanyl are just flooding the market. I'll go ahead and play this commercial.
This
Fix this. All right.
is not the pill you think it is. Because what you think is a perk or oxy could be an illegal opioid laced with fentanyl. And fentanyl deaths have tripled in the last 10 years. Just 2 grains can kill an adult like that. If it comes from a dealer and not a doctor, the next dose could kill you. Are you safe from fentanyl? Find out at SanDiegoOpioidProject.org.
All right. So those were our 3 campaigns, our 3-phase approach. And so each of these campaigns had their own media goals. And these span across visibility, which we call reach, of the brand and key messages, and then engagement and consumption of the messaging. So one, we want our audience to see the messaging, to see the brand, and then to consume the messaging. And then with campaign 3, our goals changed slightly. We made a brand new landing page on SanDiegoOpioidProject.org specifically about the journey of a laced fentanyl pill. So we wanted to make sure we were driving traffic to the website for our audience to learn more there. So with all 3 campaigns, we focused on media channels that delivered targeted visibility and reached the audience where they are consuming the messaging already. We want to engage them and meet them where they're at. So we used paid social media, paid digital media, paid search, a website, and television. So I'll very quickly touch on the benefits of each channels. So paid social media, that's Facebook and Instagram. You're all very familiar with those two channels here. This is where we wanted to reach our audience where they're online the most and where they probably are receiving misinformation about prescription opioids. So we made paid ads and promoted posts that both delivered our messaging and engaged our audience, as well as drove them to the website to learn more. Through our paid digital media, this was used to reach a specific, more at-risk audience through advanced targeting capabilities. So paid digital, we have a little more hyper-targeting than we do on paid social, just the nature of the platform. So we delivered ads, and for reference, a digital ad often looks like a banner on a website or an app. So we delivered these ads on websites and apps where our audience is already consuming content. And then paid search, this helped us reach really high quality traffic. So this reaches our audience when they're actively seeking information related to opioids, looking stuff up on Google. So these ads are relevant to the search queries that our audience is looking up, and then drive our audience to the website to learn more. And then the website was really our universal brand presence and secondary resource for the audience to consume messaging and learn more. So they either land there from a paid ad or from looking things up organically, and the website was our end all be all for San Diego Opioid Project. Everything lived there that we wanted our audience to know after seeing an ad or looking something up on Google. And then lastly, television. We had commercials placed both on Cox and Univision, so English and Spanish. And what's great about TV, it just generates that broad reach and mass awareness with really high quality and credible impressions. So we're able to reach our audience through channel and programming selections with that specific focus on Spanish audiences through Univision. So who was our target audience? Well, we know this is an epidemic in San Diego, but who specifically were we trying to reach? We were trying to reach the most at-risk folks. So our target audience was San Diego County residents ages 18 to 40 who are at high risk for misusing opioids or laced substances, aka receiving a pill laced with fentanyl. And our audience was reached through channel selection, media targeting, which ranges from geographic targeting, age, topics, keywords, interests, as well as opioid prescription data. So we used a wide array of targeting here to reach our audience. And then I'll go into these a little in depth on the next slide. So interest-based topic targeting, this is just based on our audience interest. Our audience, we know, will interact with a certain type of content, so we'll reach them wherever they may be because their online behavior already indicates to us that they're part of our audience. Behavior-based targeting, so this is classified by audience behaviors such as their web activity, so if they're going on addiction.com and things like that. Contextual targeting, this is for digital media, and it's really based on the topics of content that our audience may be consuming. So, for example, an article on extreme sports, which might eventually lead to injury, which might eventually lead to an opioid prescription, we're going to put our ad on this website so it feels like a good fit and a native fit. And then location-based targeting, of course, our audience in San Diego, as well as things like people who recently visited surgery centers, so a little more nuance there. And then a large benefit we have here at Rescue is that we work with trusted healthcare data providers. So this allows us to deliver digital ads based on different health indicators like prescription data or medical office visits, like I just mentioned. These partners that we work with have rigorous data collection processes in order to be HIPAA compliant, but they provide the unique benefit for us of reaching the most at-risk people in our target audience. So that's something that's unique to Rescue and really is a perfect fit for reaching this audience. So when we launched our campaign, we had our commercials, we had our social media, digital media, website content, paid search, television, a lot of different things going. So how are we measuring our success? We measure our success with what we call KPIs, which stands for Key Performance Indicators. So we're looking at a few things here. Message delivery, which indicates targeted exposure to the message, and that's measured by impressions. Impressions are simply like eyeballs on an ad. So that's awareness. And then we also look at exploratory engagement. So this shows us that our audience is consuming our content. And we can tell they're consuming it because we're looking at things like video completions, reactions, likes, GIF completions, clicks, web sessions, and more. So those are our main two KPIs, but we also looked at active engagement too as more of an added bonus. And this indicates that our audience is going a step further from exploratory engagement and really interacting with and amplifying our own content. And this is when they comment on stuff and share it. Okay, so now let's look at some numbers. So overall, the 3 campaigns have generated over 46 million impressions and 3.8 million engagements. Our 3 campaigns have reached 94% of our target audience. So San Diego residents ages 18 to 40 who are high risk. We reached 94% of them on an average of 43.3 times. So this is fantastic. We are absolutely thrilled with these numbers, especially those impressions. 46 million is huge. So this campaign did exactly what we wanted it to do. We reached a lot of people. We were able to reach them multiple times, and we were able to see them engage with our ads. So really, really happy with these numbers. And I think it just speaks to the efficiency of both our paid media and the strength of the creative. So speaking of creative, we pulled out some top performers from each campaign. So these are all called GIFs. It's kind of like a moving image, not quite a video. We know that our audience, just like a marketing 101 thing here, people interact with GIFs a lot more than they do a static still image. So GIFs work really well. These are 3 GIFs, one from each campaign that performed the best for each one. So the first one in Rabbit Hole, 47,000 post engagements for this GIF here, talking about how mixing alcohol with opioids can shut your body down in your sleep. When we saw this, when we first read this campaign, we thought it was interesting that this one did so well because our second campaign was all about mixing with alcohol. So this just showed us, hey, we're reaching the right people and our next campaign is on track. So the next one, No Drama, No Help, our top performing GIF here with 37,000 post engagements. You see it says sleeping it off or dying while asleep. So, really capturing like that fear ethos there. And then for instant death, our top gift with 19,000 post engagements, illegal opioids could be laced with deadly fentanyl. And you see a young lady here who's overdosed. These are our top performing creatives. And with each campaign, we saw certain themes in our social conversation. So I really want to touch on this for a while because we know we're reaching our audience. The numbers speak for themselves, but that's quantitative data. What are we seeing from our audience? So let's take a look here at qualitative data. So in the first campaign, Rabbit Hole, the main themes we saw when people were responding on Facebook and Instagram to us, we saw people sharing their appreciation for the brand, agreement with our message, and then we also saw a lot of opportunities where we could step in and correct misconceptions and educate our users on a personal level. In campaign 2, No Drama, No Help, we saw a lot of people downplaying the severity of overdoses. A lot of trolls in this campaign, I'll say, which, that means we're reaching the right people. They think we're not serious. They're like, oh, I've taken pills, I'm fine. Guess what? That's who's probably going to end up accidentally overdosing, and that's exactly who we want to educate. So not necessarily those who already know the dangers. We want to reach those who are at risk. So this gave us an opportunity to further educate these people and emphasize the increased risk of mixing alcohol with opioids. And then in campaign 2, we also saw users sharing their personal stories and losses to opioids, as well as an appreciation for our brand. In campaign 3, Instant Death, we saw again people sharing personal stories, which to us is a huge win that they're willing to be that vulnerable with us, and gratitude for our work to protect San Diegans from opioid-related deaths. In addition, in this campaign, we saw a lot of people tagging their friends in our content, so we were once again able to provide our audience with resources and serve as a reliable source of information to build that brand trust. So these are just some examples. For the sake of time, I'm going to go through these fairly quickly, but we can just look at a couple here. So these are examples. I'll let you read more on the screen, but of each of the themes we noticed from the campaign. So in campaign 1, we have an example here about our audience showing support. This person says, finally, some awareness. There's people that taste these like candy. And then we jump in. Thank you for your support. We want to make sure everyone knows the risks. Theme 2 here, where we're correcting the misconception. This person, it's a long paragraph, I won't read the whole thing, but basically saying like, stop demonizing us. Not everyone on pain pills is an enemy. And we're saying, that's not our intention. Our goal here is to really help educate people on what opioids are and how to use them safely. Jumping into No Drama, No Help, our second campaign. As I mentioned before, a lot of people downplayed overdose and they got really cynical about it and even made like dark jokes about death. This campaign, out of all 3, we saw the darkest comments on social media, but you know what? That's who we want to reach. So an example here, this guy's like, that's no big deal. He just popped a couple Xanax bars. And we're like, actually what you're seeing here is someone unconscious after mixing opioids and alcohol, and that's very serious, et cetera, et cetera. And then the second example here is just someone showing brand support, saying, keep up the good work. Here are a couple more for campaign 2. People sharing personal stories. Here, I had a friend affected by opioid abuse. It was really hard for him. Of course, we always come in when people share with us and empathize with them and make sure they're heard and, really want to build that connection with them. And then theme number 4 here, serving as an educational resource. I love this example. This person asked, is abuse different than addiction? And like, yes, abuse, more commonly referred to as misuse, and addiction are very different. And then we go on to explain the difference. An instant death, here are a couple of examples. So theme 1 here, serving as that educational resource. So this person, see the second comment, how does fentanyl hide in an opioid when it is an opioid? So it hides in itself. And so we come in, you're correct that fentanyl is an opioid, but we're highlighting here that your illegal pills could be laced anytime, anywhere, by anyone, and just one tiny dose can kill you instantly. And then a second theme here, people tagging their friends, or at least mentioning their friends. So this person, doing a line of blow could kill you. It killed 3 people at a house party in Ocean Beach not too long ago. I hear people are mixing that stuff with Coke. So here we're getting like that local example from our user. And we're saying, yes, fentanyl can be laced in a number of drugs and it only takes a small amount to kill you instantly. So those are some examples. A couple more here. Personal stories and brand appreciation. But again, for the sake of time, I'm going to keep moving. But I'll be sure to get these slides out if you all want to read these comments later. Okay, so San Diego Opioid Project.org is our website that we built at the fruition of this 3-phase campaign. And this is where we had all of our paid media driving to, as mentioned before. So across all 3 campaigns, we garnered over 30,000 website sessions. So that's when someone's on the site for 30 seconds or longer, with an average session duration of 31 seconds. However, we saw the longest session duration in our 3rd campaign at 38 seconds. And we believe that's because we built a brand new landing page on the website all about the journey of a fentanyl-laced pill. So we were driving a lot of traffic to that new page so people could learn about, you know, how is fentanyl laced, where is it laced, why is it dangerous? And if anyone wants to check this out, you can go to San Diego Opioid Project.org and check out the different sections on the website as well as the fentanyl page. And then just holistically, the website, in addition to the fentanyl page, we talk about what are opioids, the stages of addiction, the stages of overdose, and how prescription opioids can affect you. So really the site served as a holistic brand hub for us. Okay, so let's wrap things up. I'm gonna go ahead and look at our summary slide. So here are some key takeaways from each of our campaigns. Campaign 1, rabbit hole. We saw here that by concentrating our media investments on certain channels really help us to increase our frequency. And frequency is how many times you hit your audience. So reach and frequency are 2 things in the media world that we always look at. After campaign 1, we realized, you know, we really want to hyper focus our media dollars on digital and social because that's really working well for us. So that's more of a tactical optimization. In campaign 2, no drama, no help, we saw that our content that localized the opioid message resonated with our audience the most and drove the most engagement on social media. So we had some ads that were very specific to San Diego, and those performed the best, which is great. And then our takeaway from campaign 3, Instant Death, was that by really keeping a close eye on social media, we were able to quickly pivot on specific creative that was not communicating the intended purpose. So we saw here, some people were seeing our facts about why dealers will lace their pills with fentanyl. It's a profit thing for them. But we saw people were taking this almost in like an advice way. So we had to quickly, you know, alter our creative there to be like, this is why it's being laced, but this is why it's super dangerous. So overall, we had a very vocal audience on Facebook and Instagram, and we kept 9 to 5 every day, responding to comments, taking learnings from that, and then tweaking our creative as needed to make sure our message is reaching them. So looking forward, now with the conclusion of the San Diego Opioid Project and our 3-phase approach that ended mid-October, we're continuing this traction. You know, it's very unfortunate that the opioid epidemic and both the extreme rises of fentanyl-related deaths is happening, but you know what? It's here and we're going to address it. So with the wrap of the San Diego Opioid Project, HHSA, the San Diego Health and Human Services team, launched another campaign all specifically about fentanyl. So we're calling it the Fentanyl Warning Campaign. This just launched at the end of October, and it runs across paid social, out-of-home, which are billboards, as well as internal posters distributed in the communities of San Diego. So these ads will continue the traction started by the San Diego Opioid Project and hone in even more on fentanyl. And with that, I'm going to turn it over to Dr. Luke Bergman to speak more to the fentanyl media campaign.
Cool. Thank you so much. And I think that Sarah or somebody else is going to run slides. Great. Okay. So thank you again, Alyssa. That is like super impressive collection of information and body of work that you guys have accomplished. And I know everybody on this call, I know really appreciates it and finds it resonant. This is I'm going to talk through this really quickly, and it's going to be sort of just an addendum to the presentation that Alyssa just gave, and what she was just referring to, you know, tease this up exactly. I think a note I would just make, and I think we see some of this in how, you know, what's so cool about the San Diego Opioid Project is not just that it's a campaign, but it is, you know, it's a space for dialogue. And you know, whereas so much of what we think about as you know, kind of public health driven communication is more unilateral than bilateral or multilateral, which is what the San Diego Opioid Project has managed to achieve, and some of why that's so cool, and frankly just critically necessary, is because we're in a moment when the dynamics around harm related to substance use are shifting so wildly. So sorry, of course, as soon as I start talking, my phone is now ringing off the hook. You know, what we see in epidemiology is just shifting so dramatically in response to the pandemic, and with respect to behavioral health around harms associated with substance use more spectacularly than anything else. There's lots of talk about the likelihood of increased rates of suicide in the current moment because of all of the anxiety and depression that people are experiencing. We know from community survey data that rates of severe depression are increased by 500%, but really where we are seeing most harm is in overdose death data, where in the month of August, for example, we saw increases in numbers of overdose in San Diego County that were just quite alarming. We had over 4 deaths per day in San Diego County as a result of drug overdose, and or half of those in the month of August involved fentanyl. A number of reasons kind of contributing to that one could trace directly to the pandemic: disruptions in supply chains, people being alone. And so in cases where they're using substances at more risk of overdose death, because even if there, you know, would be naloxone around, there would be no one to administer it. And then also disconnections from care. We saw really profound disconnections from substance use disorder treatment right in the wake of the pandemic and public health responses to it. So what we started talking about in this context, in the context of this very meeting, as we were starting to get a sense for some of those overdose death trends locally, was, holy crap, we have to right now communicate with our community about what we're seeing happening. And we have to do it as expediently as possible. We have to do it as broadly as possible. We have to do it as clearly as possible. Can you advance the slide, Sarah? So it was in the context, actually, of an executive committee meeting that several of us were you know, felt just like a sense of kind of dire need to make this communication happen in ways that I just described: fast, concise, clear, and effective. And so we put our heads together and talked about what would make sense. Terry Perez was instrumental in those conversations, but representatives from, I think, just about every institution that has a representative within the Prescription Drug Abuse Task Force was substantially and really usefully involved in those initial conversations. We didn't have lots of people, but we had, I think, lots of varied representation. Terry Perez had actually produced a little flyer already that you know, that she was distributing through her networks, that was you know, that had some really key information, but that of course you know, wasn't informed by all of the kind of miraculous stuff that communications firms can lend to you know, to this kind of effort. And so we took what Terry had developed, she shared it with all of us, and started a conversation about how we could optimize it. and kind of make it as accessible as possible and as clear in its messaging as possible, and as make it something that folks we would really want to reach would be as receptive to as possible. What we decided the fastest way towards the optimization of Terry's flyer would be to just connect with county communications, because they were sort of like at the ready to do what it is that we would need to do. So we took what Terry had produced, gave it to our county comms colleagues, and iteratively produced the two flyers that you see towards the right side of this slide. And the iterative process through which Terry's flyer kind of became these two flyers, I think is really instructive, and also just really frankly gratifying to see as a participant in this forum, because again, everybody was weighing in. Every institution that's represented here was really thoughtfully weighing in on the aesthetics, the messaging, and so the language, the images, how things were sort of composed, what should be, sort of the kind of highlighted direct imperatives that we would want to put in these flyers. And and there were recommendations coming from places that one wouldn't necessarily have expected them to. It was very, very collaborative, and a very dynamic, kind of dialogue that we were having that led over time to what you see on this slide, and to these two images that you see on this slide. And we pretty immediately, as soon as we decided that, okay, these are good from county comms, great, let's just get them out through the cascades that we've got on hand. And so we did that. But of course, placing ads is something that, that is best informed by its own science. And there is kind of incredible expertise on hand in that. And we knew that we weren't availing ourselves of that by just kind of emailing this stuff out. So with an arrangement that we already have within Behavioral Health Services at HHSA with Rescue Agency, with Alyssa and her team, we engage them in helping us to further optimize the messaging and the creatives, I guess you all call them, and then also in getting these things out to the broader community, making sure that the messaging was in fact being seen by folks. So please advance the slide. Importantly, of course, this was happening both in social media spaces, so resonant with what Alyssa was just describing, but then also in out-of-home placements. And what this slide shows is just kind of like dates of launch and duration of campaign. We used actually some CARES Act funding to support this, which is easily justified in the fact that it's quite clear that the dynamics that were unfolding were part and parcel of the pandemic, and that it kind of enabled us to pour more money into this, and also the durations with which we're working work well with applicability of CARES Act funds. Can you advance the slide? So these are some of the creative assets, and these are obviously in English, and are web-click ads in social media. They take some of the images that were from the initial county comms work and some of the just kind of overall aesthetic there, but obviously refine it really nicely, and then also involve new images altogether and kind of a new set of aesthetic themes. Could advance the slide. Here's in Spanish. And again, these are web-click ads that do navigate folks toward direction about access to care and also access to naloxone, which is a kind of highlighted piece of this work overall. Next slide, please. I think the the numbers that Alyssa was reporting on before regarding the opioid project are super impressive. I think these are also very impressive given how long this stuff has been out. So these are social media metrics only. Over 500,000 impressions, over 10,000 exploratory engagements, and edging towards 1,000 active engagements in what has been a relatively brief period of time out in the world. And so we're quite gratified to see that. Next slide, please. These are some of the out-of-home placements. Billboards and posters like this that you see mocked at a bus station. Again, reminiscent of initial county comms work, but better, unquestionably, and involving now, I think, kind of a branded a phrase, fentanyl, San Diego's hidden killer, which I think is, hard hitting and really effective. Next and last slide, I think. Yeah, so just to give people a sense for kind of plans to cite out of home ads. You can see both billboards with the black pegs and transit shelter ads with the blue here. And Rescue anticipates that there will be anticipated impressions just with the fentanyl campaign during this duration of around 16 million, which again, I think is it's a good number to see. This is not the kind of impression that we could achieve without the involvement of an agency like Rescue. At the same time, the speed to ground that we achieved in getting this messaging out with the quality that it reflects wouldn't have been possible through kind of like normal outsourcing engagements. And so I think it's a credit to the structure of this forum and to our commitments to work with real senses of urgency in real time that has led to this kind of really gratifying metric. That's all I was hoping to say. So thank you so much.